Hi, and welcome to Conversations in Interventional Cardiology. My name is Andy Goldsweig, and I'm the Medical Director for Structural Heart Disease at the University of Nebraska Medical Center, and proud to be an Associate Editor of JSCAI, the Journal of the Society for Cardiovascular Angiography and Interventions. I'm honored to represent JSCAI and our Editor-in-Chief, Dr. Alexandra Lansky. You can find us online at jscai.org, JSCAI.org, and follow us on Twitter at myjscai, at myjscai. JSCAI is the official journal of SCAI and the home of all official SCAI documents. We're here today for a very important session to discuss a recent state-of-the-art review published in JSCAI. The title of the review is Left Atrial Appendage Occlusion, Current Stroke Prevention Strategies, and a Shift Toward Data-Driven, Patient-Specific Approaches. I'm thrilled to be joined by a panel of internationally renowned experts today. Dr. Ellen Roche, senior author of the paper, is a biomedical engineer at the Massachusetts Institute of Technology, go Tough Beavers, with numerous medical innovations and inventions to her credit. Dr. Wang, also an author of the paper, and the director of structural heart imaging at Henry Ford Health in Detroit, Michigan. Dr. Renu Virmani, a cardiac pathologist and president of the CV Path Institute in Gaithersburg, Maryland. To begin, I'd like to direct a question to Dr. Roche. Over the last 2 decades, left atrial appendage occlusion has moved from a drawing on an airline napkin to really a mainstay of stroke prevention for patients with atrial fibrillation. Now, in this paper, you and your colleagues describe the key design aspects necessary for effective left atrial appendage occlusion. Can you summarize your group's work for our listeners?
Sure. Hi, everybody. It's a pleasure to be here. So our paper is a review paper with some key takeaways. We wrote this primarily from an engineering perspective and discussed the design aspects of LAA occluders. So we start with a thorough description of anatomical and both physiological and pathological left atrial appendage considerations, especially those related to stroke in the context of atrial fibrillation. And then we give a discussion of prevention strategies that are currently utilized in managing stroke in patients with atrial fibrillation. So these slides kind of summarize our review paper entitled Left Atrial Appendage Occlusion, Current Stroke Prevention Strategies, and a Shift Towards Data-Driven Patient-Specific Approaches. And this was co-authored by my graduate student, Keegan Mendez, Dara Kennedy, who's at Columbia, who did some work in my lab as a visiting student, and then Dr. Wang, Dr. Brian O'Neill, and myself. So at first, we just give a kind of an overview of the anatomy of the LAA within the heart and a description of how clot forms in the left atrial appendage and discuss a little bit the factors contributing to this clot formation. This is not new to probably anybody listening to this, but just to set the scene. Then we give a description of commercially available CE-mark approved percutaneous left atrial appendage occluder devices. So there's quite a variety of these as shown here, and we discuss each of them in quite some detail. We then give some CT and transesophageal echo images of device-related thrombus, which is detected during imaging follow-up. And this is to point out some of the things that can go wrong with these occluder devices. As I mentioned, we are interested in using patient-specific benchtop models. And this figure in the paper, or this first part of the figure in the paper, shows how some of these 3D printed models can be used for testing devices in left atrial occlusion. So you can see the Watchman device being implanted in some of these 3D printed models that are patient specific on the left, and then how these models are constructed on the right, from a 3D transesophageal echo scan to a 3D reconstruction in silico, and a 3D printed model that can be then used to test the Watchman. And you can see the fidelity of these models is quite good. Again, this slide just shows further, these models were derived from CT images of patients, which you can see the various anatomies that can be printed, and it gives a really good estimate of how the occluder will sit in the left atrial appendage in these patients. We're also a big believer in using computational models. This just shows a workflow from FEOPS, where you get input from clinical images and mechanical material properties from devices, and you process them with a finite element computer simulation. And the output, then you can get very detailed description of dimensional and positional analysis, and you can do a kind of a parameter study and a sensitivity analysis of how things will look depending on how you position them. So you can look at optimal and suboptimal options, and this can all happen in silico before the patient is treated. Further models computationally are shown here. On the top is a computational fluid dynamics model showing velocity waves in normal and atrial fibrillation in different types of left atrial appendages. So you see the windsock and cauliflower. This can explain some of the clot formation. The second part of the figure here shows a finite element model with different devices implanted and different positioning of these devices analyzed. I mentioned we're interested in higher fidelity benchtop models. So this shows some of the devices or the models that we've developed in the lab, where we can 3D print molds and cast patient-specific left atrial occluders, and we can put soft robotic actuators around them so that they actually contract like the left atrial appendage. And we can tune this actuation to match the pressure waves and vary the input pressure to these actuators to achieve various pressure waveforms inside the appendage. So then when we implant the devices, it's in a dynamic contracting environment with physiological pressures. So to conclude, we present this vision flowchart of how potentially left atrial appendage occluders could be made to be patient specific. So we could take a patient who requires left atrial appendage occlusion, do CT scan, segment the LAA, make a very high fidelity CAD model of the occluder. We could either print the model or the device itself and evaluate any type of occluder in a very high fidelity patient specific model. We could also use computational models to evaluate how that device might look like in this specific anatomy. And we hope that this would lead to left atrial appendage occlusion procedure with improved outcomes.
That's really an incredible summary and really a survey of an incredible leap in technology from, a nitinol device that squeezes and assumes various conformations in any patient to an individual personalized device that would actually be designed to fit an individual's anatomy.
Yeah, and I think I will add to that, there are regulatory considerations with very patient-specific devices, but even as a first step, if we can make patient-specific testing benchtop models and evaluate the right device and the right, location and everything to place it in, that could be a first step towards customizing the procedure towards patients.
That's an excellent point. The paper really emphasizes the importance of imaging to guide personalized stroke risk prognostication with fluid dynamics models, and then personalized left atrial appendage occlusion therapy. Dr. Wang, I'm turning to you. You have a very well-deserved international reputation as an expert in 3D modeling of the left atrial appendage, and particularly 3D printing of the left atrial appendage. So I wondered if you could tell us a little bit about why 3D modeling, pre-procedure planning, and benchtop device testing are so important for the field for achieving a good and effective implant.
Absolutely. It was a true privilege to work with Dr. Roche and her lab. The paper, the review that she invited us to be co-authors on, it's kind of an understatement of the tremendous work that she and her lab are pioneering right now. When we started doing CT procedure planning for left atrial appendage in like 2014, 2015, that was based on our knowledge of doing transcatheter aortic valve replacements and knowing that that was going to be effective. So it was kind of a no-brainer that it was good for the aortic valve, which is a complex structure. Why wouldn't it also be good for left atrial appendage, which is much more complex? We had the privilege of having Dr. Virmani on with us tonight, and one of the things that we try to aim for is maybe 1/10 the understanding of the anatomy that Dr. Virmani has for left atrial appendages. And what we have found is that it's such a complex structure, the procedure itself is even more complex than a transcatheter aortic valve replacement. So when we first did the 3D printed models, it was to help us understand where was the device actually going to land in the patient. So without actually having to go in with a two-dimensional imaging technology that we already knew in the TAVR literature and TAVR experience was going to be insufficient. So we first 3D printed these models, not for patient-specific devices, but just trying to figure out what device should we actually put in the patient for the accurate size, and what kind of methodology and protocol can we do that's safe and reliable that we can actually accelerate. The fascinating part about the 3D printed models now is that, when we first started doing this in 2013, it was just a hard piece of plastic, the cheapest thing we can do. Now you have advances like Dr. Roche's lab, where you have silicone models, soft ones, that you can actually do input PSI pressures. And what's very attractive for that now is imaging. We need to push the boundaries. We first put LAA out there in 2014, 2013 as how to get a device in. But now that we know that not every device works well, some have leaks, some have cants, some have torque on them, we're now moving to is it patient-specific device, or do we need better simulation testing beforehand? And one of the things Dr. Roche's lab is often looking at is also flow modeling. And what we need to see in the imaging world is predictability. Who's going to have the device-related thrombus? Who's going to actually have the best optimal deployment and sealing? And we will know that eventually clinicians will find this to matter and be of importance to device selection. But it did start with a 3D print, just so that we can understand where a device goes. But now that we've accelerated 5-6 years in technology, understanding and imaging, we're hoping that with Dr. Roche's paper and Dr. Virmani's expertise on anatomy, we can push the boundaries to really figure out what do we do for the optimal patient then, so we have success both short-term and long-term.
Wow, so that really is a paradigm shift in terms of pre-procedural planning.
Absolutely.
Maybe if I can ask you just to get a little bit concrete for a second, could you describe kind of what your current pre-procedural planning looks like and what you would conjecture it might look like in 5 years?
Well, absolutely. It does not involve a pre-procedural TEE. So nobody has to do a pre-procedural TEE. We do a pre-procedural CT for the patient. So they come in during a clinical visit for the left atrial appendage evaluation with the implanting team. They go to the CT scanner. In the 2 minutes, they get a CT scan. They go home and we size their device and we see what the appendage looks like and what the deployment angles will be. And then they get scheduled for their actual procedure. The day of, we do an interprocedural TEE to help guide the transeptal crossing and device implantation. And then just to follow up on the 45-day, we do a post-CT. We find that to be comfortable for the patient, effective, safe, and we can find out tear device leak and thrombus effectively too.
You mentioned intraprocedural TEE. I know we offline have discussed this a little bit previously, but I wonder what your thoughts are on alternative intraprocedural imaging modalities, fluoroscopy, which can be the straw man, and intracardiac echo, particularly 3D intracardiac echo.
I'm not sure there's going to be a role for fluoroscopy in the next 5 years. And fluoroscopy is always a safety net. But I think intracardiac echo and other intracardiac imaging devices will be a future that should be invested in. The main problem with that right now is accessibility. Most industry devices, companies for intracardiac echo cannot scale, meaning that they don't have enough supply chain abilities to provide enough catheters for us to use for that. And there are devices that are better off with certain devices for imaging like intracardiac echo that don't have evaluation criteria for looking for leaks afterwards or sizing such as that. But one of the other hurdles that you and I have talked with SCAI, which I'm very, very proud to be a part of SCAI, is that there's a lot of motivation and movement towards supporting interventional imaging physicians in guiding the intracardiac echo. You and I are very well aware that intracardiac echo will be the future for left atrial appendage imaging and procedure, but currently the billing code is only restricted to use by interventional cardiologists. There's a billing code available, but if I was to hold a probe or another interventional imaging physician cardiologist, they cannot be billed. They're not allowed to use that billing code. So I think there's a lot that we can do from SCAI to help advance the field and advance the actual technology too. So it's not just TEE, it's a short answer.
Excellent. Thank you very much for expounding upon that. I'll tell you, yes, I agree 100% that 93662 is simply inadequate, especially in the realm of 3D intracardiac echo, where the interventionalist is simply placing the catheter into the left atrium, and then the imaging physician is really working the magic, manipulating the plane digitally and generating all of the images.
What is the beauty of it, though, I would have to say, is that what Dr. Roche has been doing with the flow modeling, Dr. Virmani has her expertise on the anatomy, we still don't know enough. So when we talk about imaging technologies and doing the devices and implanting them fast enough, there is so much that these two professors can teach us that we should be really, really carefully listening to on repeat over and over again.
Excellent. Well, I want to turn to Dr. Virmani, if she doesn't mind. Dr. Roche really described a fantastic modeling system, and Dr. Wang has described some incredible imaging. You're at the forefront of this field, and you've definitely directly inspected more left atrial appendages and occlusion devices than almost anyone in the world. The review really emphasizes that optimal left atrial appendage devices should minimize the strain on the left atrial appendage and the surrounding cardiac anatomy, and should minimize peri-device leakage. I wonder if you could tell us why these design considerations are so important, kind of shed some light on what the designers need to do to be effective.
I mean, I think without knowing all the stress strain and where it's going and the area where it goes into the left atrial appendage, we know that there are so many different ostia of the left atrial appendage shape is so different. Round, elliptical, teardrop, you name it, every name has been applied. And it is very hard to put that a few of the devices, which are, most of them are round, yet the orifice is not round. So the question really is, stress strain is going to make a big difference. And also if it fits appropriately into the ostia and where it lies in the ostia. I think it should be planned before exactly where you're going to locate it. And without the anatomy, it's impossible to know where you're going to locate. I think the old days when they used to do it without CT and not knowing the anatomy at all, I think no wonder we fail so much. I think things will change because of the new aspects of how we're learning. And I think the thickness, one of the things I was going to ask is, the thickness of the atrial appendage also varies. Some areas are very thin, some areas have much more muscle, and that may play a role in how it interacts with the orifice. And you're not able to do such detailed anatomy to be able to know that, there are divots and there are no divots. And if there are no divots, you're okay. But once you have divots in that area, you're going to have a problem. And the orifices and also the shapes are different. Some are round, some can shape differently because of the stress strain. They acquire a different shape, and I think that makes a difference. And of course, healing varies from patient to patient. What we learn from animals is so poor. We learn that everything is healed by 90 days in these animals when we implant normal animals. And these are young juvenile animals. Everything heals faster. When you look at it in man, it takes many more months than it would. I can tell you for a stent where we've actually done a comparison, what takes 30 days to heal in man takes 6 to 9 months to heal. So to be able to say that the surface gets endothelized, absolutely not.
So a lot of anatomic variability. I wonder, do you see specific anatomic features that you think make devices more prone either not to heal or endothelialize, or to retain some peri-device leak?
I think partly peri-device leak is to do with the device, how it's been located, where it is lying in the orifice. That makes, is it tilted, not tilted? Once it's tilted, you don't get a good closure. So that becomes a problem. Flow dynamics change, and therefore you're more likely to get a thrombus than you would otherwise. And peri-valvular, peri-device leaks occur. So I think that also will make a difference. And those leaks change the flow around the area of the orifice. So I think there are too many variables. I actually am impressed with what has been presented and how those stress strains and how the flow, I was very impressed with the flow. I think that to me is so important to pay attention to. And if you put the device appropriately, it would change. And I would like to see in vitro that when you put a device, how does it change the flow?
Yeah, that's a very good point, actually. And that's something I think we can measure in these models, you know, before and after device placement in various configurations. What does the flow look like?
Because I think that would tell you that this device is not good. I have a question for the interventionalist, for you, and that is, because you get used to using one device, people don't like to use 5 devices differently. And therefore, once they're used to using one device, they like to stick with it. And they'll put the same device over and over again. I don't think that's the best for the patient. So should patient be, there should be a central lab which looks at the various dynamics as has been presented and says, this is the device that fits the best. Now, this is the center where they do the most with this device, and the patient should go to that center. That would make a huge difference in our outcomes.
I'll throw out my bias. I've always approached the 2 commercially available devices in the United States, Watchman and Amulet, the same way I've approached the principal 2 TAVR valves, the Medtronic valve and the Sapien valve, that for 80% of patients, either one is probably appropriate. You can achieve a good seal and a good implant. And then there are certain anatomic features that make one device potentially more appropriate than the other in 20% of patients. That being said, after I implant the devices, I only see them once more on follow-up imaging at 45 days and have been very fortunate in the however many 500 some we've done at the University of Nebraska not to see any of them in anatomic pathology. So I don't know if that's true or not. That's the bias I carry.
No, I mean, it's a valid bias. And I think definitely, I think it's correct for the valves, which we all have much more experience than the atrial appendage occluders. It is absolutely correct. You could apply one or the other and it would not make much of a difference. But I think in 20% of patients, as you said, will make a difference. And probably that is also true in the atrial appendage. So those 20%, should they have much more? Do we know in advance which those 20% are going to be?
One more question that I want to throw out to each of you is the issue of fusion imaging. Intraprocedurally, at present, as Dr. Wang said, most people are using either transesophageal or intracardiac echo with fluoroscopy as support. We have all of these incredible planning technologies, right? We can get a CT, we can 3D print, we can build a silicone model with pulsatile blood pressures. I wondered whether you had thoughts about the importance of, at present and in the future, fusion imaging. For example, putting that CT model or the transesophageal echo imaging or the 3D printed model, superimposing it on a fluoroscopy screen or on an echo screen.
Yes, we had thought about that extensively. The funny thing is we realized that there are many industry companies who have developed fusion technology and they come in pink, purple, and different shades of green. But what they don't realize is that in the fluoroscopic world is black and white, and that 10% of the implanters can't see color and they're colorblind. In females, it's only 0.1% of females are colorblind. So I think the technology needs to actually adapt to what the user's abilities to see color are, first of all. But second of all, I think there's definitely going to be a role in the future, but it comes down to a resource allocation. And how much is it going to cost for that software, hardware install, and equipment and one-time usage or 500-time usage versus just a ICE or interprocedural TEE, which is currently, unfortunately, more economical. At Henry Ford Health System, we do the interprocedural TEE. We actually take our CT case plans and we put it in a PowerPoint and we just print it off and bring in the case with us. And it's been sufficient and has worked really well. And it's just a black and white and it's enough. But there are plenty of really great technologies out there. It's just everything is a business model. And I think the value of this is definitely there. It's just how can we scale it? Dr. Roche, your thoughts?
Yeah, I agree. I think the technology can definitely be developed, but as you said, maybe need some additional considerations of the user. And I think, you know, maybe at the beginning, it may not be widely available. So I think, you know, if it can be, I think the technology can be developed, but to scale it is going to be the challenge. But
are the payers going to pay for it also? That's the bigger challenge, is the payers are not going to pay for it. The economics of today's world is that no new costs in medical care is going to be allowed, more or less.
Well, you have to demonstrate a difference in outcomes, right?
Yes.
Well, it is certain that the future of left atrial appendage occlusion is very bright and looks like it will be very personalized. Thank you so much, Dr. Roche, Dr. Wang, Dr. Virmani. It's really an honor to speak with leaders in the field, and we are absolutely thrilled to include this important paper in the 5th edition of JSCAI and to share this discussion with this incredible panel on the JSCAI website. Please follow JSCAI. The website is jscai.org. The Twitter handle is @myjsci. And please submit your own future work to JSCAI. JSCAI is the official journal of SCAI. So thank you all very much.